get started with our afternoon program, part of the webinar. But before we do that, I wanted to highlight one other resource that from Lindsay. So the National Cancer Institute has a new tool, particularly for people that are interested in getting a better sense of the codes that they may consider using for identifying therapy. So if you go on to NIH's website, seer.cancer.gov/oncology toolbox, you can see the website here. There's a listing of different cancer medications. There's a database to search based on HCPCS codes or NDC codes, and there are some other resources that are under development. So if you're interested in getting a list started of the therapies of interest, you could use this as a starting point as well. So with that, we'll go back to our slides. And first off this afternoon, Stephanie is going to discuss opportunities for measuring outcomes in the SEER-Medicare data. We'll be back in just a moment.
Hello, everyone. Sorry, I had to take the speaker chair. Welcome back. I realized that I hadn't really introduced myself when I did segment 3, so I just wanted to say hello. And I've been working with SEER-Medicare data since probably, I think, 2006, so it's been quite a long time. I started working with Dr. Vernig back then as a doctoral student, and then have continued through collaborating with the Department of Urology here at the University of Minnesota, and I also have a position now at ResDac using Medicare data. So, we've talked this morning about defining our cohort and then defining treatments using the claims data and the SEER data. And now we're going to be talking about some outcomes that people are generally interested in. This isn't an exhaustive list of every possible outcome, but we wanted to give you kind of an overview, how you might think about measuring these things, what concerns you might have, and just discuss, where you can find these things. So some of the things we'll be talking about are short-term complications and adverse events, some long-term complications, recurrence, which is often people are curious about that, survival or death, and then cost of care. So we'll be talking about each of those in turn. SEER-Medicare data really provide a unique opportunity for studying cancer because, the SEER data provide great information surrounding diagnosis and initial treatment. That's something that other claims data sources don't necessarily have. You don't have stage at diagnosis. You don't have a definitive month of diagnosis, although you can try to infer it. But you don't necessarily have, their stage, the severity of their disease. So you get a lot of great information from the SEER data. But it is restricted to that period of diagnosis and initial treatment. And then they do include some mortality data, but that's just the death data. So you have their death date and their cause of death, but you don't have anything between those two time periods. Medicare data can help us fill in the gaps. So from Medicare, you have information from the time they enroll until they either disenroll or they enroll in managed care or they die. The downside to the Medicare data is that they're claims and not clinical records. So while you might be able to measure that a biopsy was done, you don't then get to see what the results of that biopsy were. So we're going to talk about how you would use that to study outcomes. So we'll start with complications and adverse events of treatment, following treatment. Cancer treatments can result in complications, obviously. The acute ones will arise quickly during or immediately after treatment, and there can be chronic complications also that would persist after the initial cancer treatment. Acute adverse events, I'm going to talk about them specifically following surgery now. For inpatient procedures, they can be identified from diagnosis and procedure claims on the hospital claim itself. So the same hospital claim that contains the surgery, you can look at what diagnosis codes are present on that claim. All of the diagnosis codes that you see are diagnoses at discharge. So some of them will be complications of the surgery itself. The caveat is that some of the complications may actually be pre-existing conditions. So you have to really think about how you're measuring them, whether you want to see if it's something that has arisen in this patient before, this case before, so we'll talk a little bit about that. With shorter lengths of stay, now the lengths of stay have been getting shorter and shorter. Many post-surgical complications will
Press
actually...
1 to save your message. Press 2 to listen to your message. Press 3 to erase and re-record your message. And press 4 to cancel your message.
Sorry, I don't know if other people are hearing other audio.
You have not pressed any key.
Sorry, you have reached the maximum number of attempts. Call cannot be processed further.
Sorry, hopefully that will be the end of that. If you didn't hear it, I'm glad. So with shorter lengths of stay, if a complication does happen, it may occur outside the hospital. So then it will not appear on that hospital claim. But the trouble with that is that surgeons are often paid on a global basis. That's just some of that bundling that we were talking about. And that includes routine postoperative services. So if someone has a wound that's not healing well and they go and see their surgeon after they've been discharged, they may be prescribed an antibiotic or something, but we wouldn't see that visit. We wouldn't see a claim for that visit. If it doesn't require a rehospitalization, we probably won't actually observe it in the claims. Here is one example of looking at in-hospital complications. These are the types of things that you can measure. This was a group from the University of Minnesota that was looking at lung cancer surgery complications. You can see things like pneumothorax, respiratory failure. You can see cardiac complications, atrial fibrillation, for example. So with atrial fibrillation, you may not believe it's a complication of the actual procedure unless you are looking for previous atrial fibrillation claims and sort of have a washout period prior to the surgery where you're measuring whether or not they have an AFib claim. And if they do, then maybe you wouldn't count it as a post-surgical complication. You can also find wound or surgical complications, infectious diseases, renal complications. So these are the types of things that you can measure, but again, you'll have to be a little bit thoughtful about how you're going to define them, whether they're complications that you can attribute to the surgery or not. Why might it be important to look at complications? The same group looked at whether or not having a complication post-surgery actually affected survival. And you can see here that there's a difference between overall survival and cancer-specific survival, but both groups, both measures actually, any people who experienced any complication did have worse mortality at 5 years. So the reasons, I apologize for the typo on this slide, the reasons for rehospitalization may require interpretation, as I mentioned. I liked this study. This was done by Joan Warren, who helped head the SEER-Medicare program for a long time. It's an older study, but I appreciate a couple of messages from it. So one is the definition of how you might attribute things to surgery. So there's in other conditions, and then there's some things that might be related to the surgery. For example, nausea and vomiting, syncope, pneumonia. So these are things that you could make a correlation as to whether or not you can make an argument for them being attributed to their actual surgery. And then there are things that are definitely surgery related, so wound infections, pulmonary embolism, other surgical complications. And this study was looking at mastectomy and trying to understand whether the original purpose of the study was to look at outpatient mastectomies and whether or not people were having more complications that were requiring hospitalization. You can see that for the outpatient mastectomies, there were complications. Most of them were other conditions, so they were hard to attribute to the actual surgery. The other interesting thing that they found was that length of stay mattered in how you were defining complications. So if someone went to the hospital for a mastectomy and they ended up staying 6 days or longer, they had many more complications, but it may be harder to attribute those complications to surgery. You may start to wonder if some of those complications were related to a poor health status, but they did experience more surgically related complications. So looking at the rates or rehospitalization reason is important if you're trying to use rehospitalization as an outcome following surgery. Chemotherapy is also associated with complications. And since Medicare data are longitudinal, we get a good glimpse of the chemotherapy complications, especially those requiring hospitalization. So you can note that some things like dehydration, for example, it may be picked up on an office visit but never coded. But if it were severe enough to warrant a hospitalization, then we could see it. And again, you'd have to look temporally and see when do you think it would be attributed to chemotherapy or not. It requires a lot of thought, kind of a knowledge of clinical patterns to say what you think is actually going on when you observe these things. Chronic complications are a little bit trickier. They can include things like pain, fatigue, nausea, loss of function, kind of things that are a little bit more nebulous to define. Most will not require hospitalization, and so it becomes trickier to actually measure them, because if someone has fatigue, maybe they even mention it to their provider, but it never gets coded as within the healthcare claims because it doesn't matter for payment. This isn't, remember, when providers are billing, they're not necessarily thinking of researchers that are going to want to use this data to figure out the complications. They're doing it to be paid. So whether a complication appears on a claim will vary by condition. This was a study done a while back looking at men in the prostate cancer outcome study. So they were surveyed at times, many times during their prostate cancer treatment and after, to identify a variety of things, but also some complications of treatment. And this was compared to the Medicare claims. Now, something like treatment of urethral strictures, you can see has pretty good kappa, good sensitivity and specificity, meaning generally if they were treated with urethral strictures or treated for urethral strictures, it was pretty common for that to be found in the claims and for it to be correctly identified. On the other hand, something like incontinence was less likely to be found in the claims, and impotence was even less likely to be found. So unless there was a procedure associated with it. If there was a procedure, you could be very sure they had impotence, but if there was not a procedure, then it was much more difficult to actually find within the claims. So chronic complications, late effects of treatment are similar. Again, this longitudinal nature of the SEER-Medicare data makes it incredibly useful for assessing late effects. Things like randomized controlled trials often do not follow patients for a long period of time, and that makes the data useful for looking at these things. However, they really do need to be significant, something like a fracture or a second cancer that will actually be reported in the claims. It's important to include a comparison group, remember, because we're using SEER-Medicare data. Most of the people that we are looking at are elderly and have a lot of, just as a group, they have some conditions that you're going to need to look at. So one example of this is looking at late effects of treatment, the pelvic fracture following radiotherapy. I think Beth alluded to this earlier. So this was a study done by Beth Fernig and Nancy Baxter and some others at the University of Minnesota. The background is that elderly women are at increased risk of fractures, but if they receive radiation, it's known that radiation can result in bone damage, and so that may increase fracture risks. But there wasn't much known about whether someone who received pelvic radiotherapy, and they were elderly, if they experienced increased risk of hip fracture. So they chose to look at women with anal, cervical, and rectal cancers who underwent pelvic irradiation to see if they had higher rates of pelvic fracture than women with those same malignancies who did not undergo radiation. And what they found was a pretty consistent pattern, that women who were irradiated did end up having more fracture. Now, one of the difficulties with this is that these are women who we are just observing. We see the treatment that they received, but we don't know why someone was not irradiated. Maybe they had poorer health status, and that put them at a higher risk of fracture. So what the investigators did was they actually then looked at women with at these same women and looked at their rates of wrist fracture to say whether or not women who had received pelvic radiation had higher rates of wrist fracture, and they did not. So they were able to fill in the gap there pretty convincingly, but just you really do need comparison groups in order to draw inference from the data. Another example, this is from the same study, and I apologize that this reference didn't appear in segment 3, but the table 1 that I was referencing in segment 3 comes from this paper. What we wanted to do was look at the long-term risk of urinary adverse events following local treatment for prostate cancer. And so we tried to carefully define adverse events that could be ascertained using claims data. And we looked, so that means using the common terminology criteria for adverse events, we were looking for things that were pretty severe, or grade 3 or 4 events. And we required both the urinary adverse event diagnosis code and a correlating procedure code. So these men had to have a problem with their urinary system, and it had to be significant enough that they both reported it to a provider, and that provider usually did a surgical procedure or something in order to address it. So these are people with the most severe events. Here's an example of how we did that. Bladder perforation was not a super common event, but just to give you an example. So we looked for a diagnosis code of bladder perforation, but then we also required that they had to have a procedure to address it, and we measured those using both CPT codes in the carrier and outpatient files, or the NCH and outpatient files, and then we looked for ICD-9 procedure code in the hospitalization files, and they had to have both the diagnosis code and the procedure code present on the same claim in order for us to count it. And here are our findings. There are a few things I want to share. We did find that acute events were much more common in men who received surgery, which was not unexpected. We knew that this was the case. What our physicians, our surgeons really wanted to understand was, well, what are the long-term effects of radiation? Because radiation, they would expect there may be scar tissue that forms. It might take a lot longer for complications to show up. So they were most curious about whether or not it sort of, after a long period of time, you saw similar findings, because their sense was that they did see a lot of men that came that had had radiation in the past who needed surgery to address things like urethral strictures or something like that. So we did find that radiation did have kind of a steady, especially combination therapies, had a steady increase over time, but they did not reach, in the end, the same rate as men with surgery, with the exception of men who had combined brachytherapy and external beam therapy. But I also want to note that our non-cancer controls also had significant numbers of urinary adverse events. We did a similar study in women with cervical cancer, and they have a very sobering rate of procedures for incontinence. So it was really important to make sure that we were including non-cancer controls to make sure that we weren't falsely, attributing all of the urinary adverse events to the treatment that they'd had for their cancer, and not realizing that there is a baseline rate, a non-negligible baseline rate among the elderly population. So if you're trying to use SEER-Medicare data to assess adverse events, if you're looking at studies that look at short-term outcomes, especially something that requires a procedure or a hospitalization, that has a lot of potential. You can feel pretty confident that you're going to measure it well. Long-term adverse events that are based on diagnosis only, especially something that may only be found in the physician data and not require a hospitalization, will likely be underestimated. So you'll have to consider that as you're trying to measure. It's probably not the best data set in order to do that. And just a reminder, the late effects of treatment will be in the data as long as the later events are significant enough to warrant being in the data, to warrant a bill that will be paid. And then use of a comparison group in this population is very important in order to draw good inference as to whether or not you can attribute these adverse events to treatment. Now, comparative effectiveness research is something that people want to do. The definition is systematic research comparing different interventions and strategies to prevent, diagnose, and treat and monitor health conditions. And the purpose is to inform patients, providers, and decision makers about which interventions are most effective for which patients under specific circumstances. And so the SEER Medicare data offer a lot of benefits for comparative effectiveness research. We know that elderly people are underrepresented in clinical trials, and this is a population base of elderly patients that we know have cancer. Also, SEER Medicare data has large numbers from multiple institutions. So what we often see are single institution studies, and the SEER Medicare data can remedy that because we have multiple institutions and we have not only academic institutions, but even public rural hospitals we can see. The data are also longitudinal, so we can look over time, and as I mentioned, randomized controlled trials often have a shorter time horizon, but the Medicare data offer a much longer time horizon. But with all that being said, we do have the problem that people in SEER Medicare are not randomly assigned to treatment, and in fact, we don't know when someone doesn't receive treatment why they don't. And so we can't necessarily say, that every difference that we see is a treatment difference, that, there are a lot of unobserved things or even observed differences that we may not be able to account for. Statistical adjustments are probably not going to be able to fix all these aspects of non-random assignment. So let's look at some examples. One study wanted to look at the benefit of fluorouracil for elderly people with stage 3 colon cancer. It's long been the standard of care for stage 3 colon cancer. But elderly patients are less likely to receive chemotherapy, possibly because of poorer health status, even though no differences in toxicity were noted in the clinical trials. So the researchers used SEER Medicare data to compare outcomes between people with stage 3 colon cancer who did and did not receive fluorouracil. What they found was, it looks pretty good. For people who used fluorouracil, they did have better survival over time. So the overall survival looks good. This was two groups that were propensity scored, they used propensity score matching to try to look at all the observed characteristics and smooth over those differences, and still found a benefit. However, we do know that there are things that we don't observe in the data. It may be that the reason that they did not receive fluorouracil had something to do with their health status and their predicted mortality. And so it's hard to draw, a great conclusion. Were the comparison groups balanced, or were the treated patients healthier? So one thing you can do is look, if the results are consistent with randomized controlled trials. Does this prove that these are effective in the real world? Because randomized controlled trials, we also know, tend to have very well-selected patients. So if they're consistent, is that okay? Does that mean that this is effective, proven? Would we believe, so if the results didn't agree with an RCT, would we believe that? Would we say, oh, it's probably because now we're looking at real-world patients, and then maybe we should change our practice? And what if we didn't have any trial data to compare with at all? Here's a pancreatic cancer example. So this is looking at comparative effectiveness of chemoradiation for locally advanced resected pancreatic cancer. So they were diagnosed with pancreatic cancer that was resectable. After they were resected, should they receive chemotherapy alone or chemotherapy plus radiation? So there was a clinical trial that reported benefit of radiation for locally advanced disease. Another trial found it was detrimental. So there's a debate about whether or not the risks are worth the benefits for radiotherapy. So NCI researchers used SEER-Medicare data to compare survival following different treatments. And this is the results. So these are people that were relatively young, age 65 to 69, white, with a comorbidity score of 0. So you can think, okay, we've really, we've gotten rid of a lot of possible differences in our groups, and this is what we're finding. Healthy, white, young patients. And we find that those that received no additional treatment were the best off. They had the best survival, while patients who received chemotherapy alone had the worst survival. So what does that tell us? Which treatment is most beneficial for patients with early-stage pancreatic cancer? This is really counterintuitive, right? So people that receive no additional treatment have the best survival. I think the data suggests that there are some unmeasured differences between the treatment groups, things that we can't really see. So you'll have to think more carefully about how you want to draw conclusions. So what that, I think, means is that using SEER-Medicare data to assess the effectiveness of cancer treatment is perilous. The results could be misleading. There are statistical methods, propensity score matching, that will help you take into account observed differences between groups. Instrumental variable analyses should help you actually kind of cover some of the unobserved differences. However, they need to be very carefully thought through as to the inference that can be drawn. And there aren't any statistical methods that are going to completely control for all of the differences between groups in analyses based on secondary data. So we definitely would recommend that these studies can be used for hypothesis generation, not necessarily for guiding clinical decisions, but that doesn't mean they're worthless. It does mean that we have really good information about a lot of people for all of those reasons, that we have longitudinal data, it's an elderly population, we have long-term, it's population-based. All of those reasons make it worthwhile, but we have to be very careful about the inference that we're trying to draw. So a lot of people are also interested in measuring recurrence. Most patients that have cancer, luckily, have local or regional disease. People are able to live longer with cancer. The cost of treating cancer has risen significantly, and so people want to know, if people receive treatment and it seems like they're doing okay, does that mean that their cancer is not going to come back? What does this mean? So can we measure recurrence? We've already said that SEER data do not have recurrence because they are really interested in the initial treatment period. Now, Medicare data could be used to infer recurrence, right? Additional treatment is usually given for recurrence. They may have more surgery, chemotherapy, radiotherapy. However, I would make sure that you call this treated recurrence, because not everyone who is diagnosed with a recurrence will receive treatment. There are also ICD-9 or 10 diagnosis codes for metastasis, and we'll talk a little bit about how those line up. You could also possibly use entry into hospice as evidence of recurrence, or even if you can use the cancer-specific mortality, you can say they died from their cancer, we can infer that they probably recurred. So let's start with talking about treated recurrence. There are investigators who have done it. You'll find papers looking at recurrence and progression based on definitions of, well, they've received this treatment, so I'm going to use that as evidence of recurrence. But again, remember that not everyone who recurs will actually get additional treatment, especially among the elderly. For SEER, Medicare, breast and colorectal patients, stages 2 or 3 disease, about a third of the patients received additional surgery, chemotherapy, or radiation when they first recurred. But patients 75 and over were a lot less likely to receive additional treatment. So, that's about 2/3 of patients that you're missing, and it can be greater for older populations. Patients treated for recurrence with oral drugs will be missed unless you are limiting your analysis to patients with Part D coverage as well. So that's also something to take into consideration. If you're looking at treated recurrence, you may want to consider, looking for gaps in treatment. So if chemotherapy is given 4 months after surgery, might it be adjuvant? Might it have been planned? You'll want to kind of, clinically assess what do you feel defines recurrence versus could be a planned treatment. It can also be hard to gauge progression for cancers that are treated with a watch and wait approach, like prostate cancer. It may be that you initially there's a watch and wait approach, so you don't observe any treatment. You may see a biopsy, and then maybe are they going to get treatment after that? It's hard to say what's going on with the progression of their disease. You'll also want to watch your definitions. As I've mentioned before, I'm really in favor of defining, if you're going to be using treatment to define recurrence, that you call it treated recurrence. There was one paper where they looked at radiation chemotherapy 6 months after diagnosis as evidence of recurrence. The authors classified the people who did not have radiation as having disease-free survival. That is not technically correct, right? Some of those people may have actually had disease, but they were not treated for it. So what we should really be saying is that they had treatment-free survival. Now, as I mentioned, there are ICD-9 or 10 codes that are indicative of metastases. The question is how evenly they are coded. So if we just look, we do have information for people who are metastatic when they are first diagnosed. We have information in the SEER about that. And then we can look in the Medicare claims data to see how often we actually observe the diagnosis code being billed. So you can see that it's pretty consistent over time, that if someone is diagnosed as metastatic, we have that information in the SEER data. It's maybe 40% less, just less than 40% of the time do we actually find a code within the Medicare claims that's indicative of that. On the other hand, if they say that they are not metastatic in SEER, it is often that the Medicare claims confirm that. You do see this 1 to 2% of people who, according to SEER, they do not have metastases, so the Medicare claims don't agree. Again, that 2% is something that you can be uncomfortable with, but you have to make a choice based on your own research study whether or not you want to believe that the Medicare claims are correct in saying that they have a metastasis. You may choose to say, I'm not really sure what's going on. So you can just make your own decision, but sometimes we do see things that don't match up. So then there have been a couple of studies that have looked at whether or not metastasis codes on claims are better at a time after diagnosis. So one study used CanCor's data, cancer portion on outcomes, something. I can't remember the acronym right now, but they used CanCor/Medicare information, and then they also looked within Health Maintenance Organization and Cancer Research Network data to identify patients with claims for metastasis or chemotherapy after initial treatment. Their findings were not great. They found that no code set that they tried to use was highly sensitive and highly specific. So really, codes from claims, their conclusion was that codes from claims should be interpreted with caution. Another study did something similar using outpatient electronic health record data linked to medical and pharmacy claims. They found the positive predictive value of metastasis identified from claims was 0.75 to 0.86. So the specificity was not bad. The sensitivity was not as good. So their conclusion again was, if you really want to be accurate with understanding if someone has developed METs, that you would use access to medical records or other confirmatory data sources. Sometimes people also would use treatment patterns indicative of metastasis to indicate or to get an idea that someone has had a metastatic progression. And again, you just have to be clear that those are only people who are treated, not necessarily people who developed mets that were not treated. So sometimes people will use entry into hospice or death from cancer as evidence of progression. So there are diagnosis codes on the hospice claims. You can see why they are entering hospice, and if it's if it's a breast cancer diagnosis on the hospice claim and their treatment for breast cancer was 2 years ago, you may say, okay, this is indicative of a recurrence. You can also find cancer cause of death on the SEER data. One caution, if you decide to use multiple measures of recurrence, so you're looking for treated recurrence or entry into hospice or death from cancer, just remember that if the entry into hospice and death from cancer, they'll show up later than the treated recurrence. They may have recurred and it will take longer for the entry to hospice or the death to actually occur. And so that could introduce bias depending on the time from recurrence to death. So just remember that. And disparities in treated recurrence will also increase bias. So if certain groups, older patients, for example, are less likely to be treated for their recurrence, that will also could introduce bias into your study. So again, my conclusions are largely the same as for comparative effectiveness research. You really have to be very thoughtful about what you're measuring. Be careful when you're reporting, report your limitations, and be careful with your terminology. And again, I wouldn't necessarily use SEER-Medicare information for guiding clinical decisions, but it is very helpful for hypothesis generation and confirming things. And if you can have a really well-designed SEER-Medicare study, it can be very informative for clinicians and patients and policymakers. Mortality data. So if you are interested in measuring cancer deaths or survival or overall survival, you have a couple of choices. So SEER will provide month and year of death, and Medicare actually gives you a date of death. Most of the time, the Medicare date of death, you will, it's extremely accurate, like 97% of the time you will never find a Medicare claim that occurs after death, but there is, sometimes you will find something that happens, or maybe they're discharged a couple of days after Medicare says they've died. Again, that's less than usually 1 or 2%, but just something to note. But Medicare has a vested interest in, they don't want any benefits to be paid out after the date of death. Dates of death come from the Social Security Administration in general. There are some other sources of death, so you'll have to kind of keep that in mind. The other things to note is that SEER dates of death are reported through the year of case ascertainment. So if your SEER data go through 2013, then you'll have deaths through the end of 2013. Medicare date of death is reported through the final year of claims. So you have that, you have a little bit more observation for date of death on the Medicare side. However, and I should note that there's also a very high concordance between the two, but I want to note that SEER is the only source that we have for cause of death. And so if you're trying to combine the two, if you want the extra observation period of Medicare, you have to note that you aren't going to have cause of death for those that final observation period. And then also just note that if you have a non-cancer control population, you're not going to have a cause of death for them because you will not have any SEER data for them. So if you really want to attribute cause of death to cancer, you're limited to SEER. If you want any information about other causes of death for a non-cancer population, you're limited you don't actually have any information on that. So cause of death reporting, this can be tricky. Many elderly have more than one cancer, which might make it difficult to attribute a cancer death to a specific cancer. And the cause of death may be miscoded. So if a patient has lung cancer and then a brain met, it may be that their final cause of death is listed as brain cancer. So it's really important to you to be able to attribute the cancer-specific cause of death. we would recommend that you limit it to, they've only had one, this is their first primary cancer, and then you assume that if there's a cancer cause that's listed, that's what the result of their cancer. You may also have trouble for someone if they have lung cancer and they died of pneumonia. Would you attribute that cause of death to lung cancer? You have to kind of be thoughtful about how you want to do that. Oh, so why does it matter? Why, if cause of death might be a little bit fuzzy, why might it be important? Here's an example. The best treatment for men with localized prostate cancer is still up for grabs. Most men with localized prostate cancer will not actually die from their disease. So researchers looked at SEER-Medicare data. They compared men who were actively treated, so they had radiation therapy or surgery, and compared those with expectant management or observation. And they used propensity scores to account for differences between the two groups. So that sounds all right. And found that men who had active treatment had much better survival than men who only received observation, which meant they were diagnosed and then they didn't receive an active treatment, they just were watched. However, if we then go the further step, so this is the overall survival for these men, if we go the further step to look at whether the death was actually attributed to prostate cancer, we find the difference is certainly not as stark. Well, 37, for overall mortality, 37% of men had died at 10 years versus 24% of men who were actively treated. The difference is much smaller. It's 2.5% in men who were not and 1.9% in men who were. So you can infer from that there probably were some health status differences that were different among the treatment and observation groups. So for using SEER-Medicare data to assess survival, you can get information from both SEER registries and the Medicare program, and which you choose will depend on your goals. If you need cause of death, you are limited to the SEER. But also, if you're using the two in combination, remember the limitations of each. This is something that's happened within my own research. We were looking at, prostate-specific cause of death and found, and if we looked by year and started seeing, oh, that's interesting. In the final 2 years of our data, no men died from prostate cancer. And of course, that was because we didn't have any information on cause of death those final 2 years. So just something to be aware of as you go. Next, we're going to be talking about costs and payments. So the Medicare data are extremely well suited for receiving information about payments. After all, that's what they are for. That's what the billing data are generated for. We get information both on charges and payments, including payments by Medicare and then what's left over after Medicare pays, which would be the patient responsibility. The best type of cost estimate will really depend on your research or policy question. I know we'll just keep saying that over and over again today. There's not one answer in terms of how to measure. Just to remember how healthcare payments work, we have patients who go to receive medical services from producers, from healthcare providers. In return, they pay some. But then there's also a third-party payer, and in our case, the third-party payer is Medicare. The Medicare provides insurance coverage to the patient, which means that they are the ones that reimburse the provider for most of the charges. Providers, instead of sending charges directly to the patient, they will send them to the third-party payer, and that's why we get to observe them, because a bill was sent from a provider to Medicare, and that's what we see. So first, claims data will report on the medical services that were received. As was mentioned in previous segments, the basis of payment varies by service type, and so what we actually get to observe about the medical service will vary by service type. So in the MedPAR file, we have ICD-9 and 10 diagnosis and procedure codes. Within the physician or NCH files and the durable medical equipment files, we will have CPT or HCPC codes, also some NDC codes possibly. In the hospice file, we are limited to CPT code or HCPC code, and we have information based on revenue centers that are sent from the provider to Medicare. And for the hospital outpatient file, we have HCPC procedures and revenue centers. So moving on, and I will also just want to note that although what we see about the medical services is ICD-9 and 10 procedure codes in the MedPAR file, most hospitals are prospectively paid, which means that the ICD-9 and 10 procedure and diagnosis codes result, they're combined together, the information between them is combined together into one DRG. So a patient is assigned one DRG, and that is the payment for that hospitalization based on the highest possible combination of diagnosis and procedure codes. So whatever else happened during that hospitalization, they still only get that payment based on the diagnosis and procedure code combination. And also the hospital outpatient file has a similar structure where they have ambulatory payment classifications, so it's a bit of a bundling. And hospice providers are paid per diem, not per service. So physicians are the ones that are paid pretty much on the basis of what they submit, CPT, HCPC codes, and most other providers have some other payment that's associated with these, with what they've reported for diagnosis and procedure codes. So another thing that we get to observe in the claims data are the charges that a provider submits to Medicare this is how much they say they want to be paid for this service. So again, it's set by provider, and that means that you'll see a wide variation in charges over providers. And there's also usually a large discrepancy between what Medicare actually pays and what was charged. Medicare does not, for facilities especially, Medicare does not really take into account what the hospital has sent as a charge. They pay based on their DRG, and that is what they pay, or they pay based on a previously set payment rate. One thing that I like about Medicare data is if you want to know the payment rates that Medicare sets, it's knowable. You can find it on the Medicare website. You would usually look for the final rule file for whatever service you are looking for. So the Inpatient Prospective Payment System, or DRGs, every year a final rule is published. You can find a DRG and see what Medicare is going to pay for it. Now, that doesn't necessarily mean that every single provider across the country is paid the same, because there are some geographic variations and wage index variations, but just note that the Medicare payment rate is pretty well set. Now, for physicians, Medicare does determine what the provider is allowed to charge. It's called the allowed charge, and payment comes from both Medicare and the beneficiary. And that's true of facilities as well, although the copayment and deductible structure is slightly different. Just something to highlight the difference between charges and actual payments. This is some information from the Medicare website. If you look at people that were hospitalized with pneumonia, with DRG 194, you see that the average covered charges was $28,000, whereas the average total payments was $7,250, and then the average Medicare payments was actually $5,900. So what's the difference between the total payments and the Medicare payments is what was left over for the patient to pay. However, we should note that the co-payments, co-insurance deductibles, all of that's left over for the beneficiary to pay may not necessarily be paid by the beneficiary. They may have, again, that Medicaid cost sharing. They may have a Medigap plan that will cover their co-insurance. So it is a little bit hard to say exactly what a patient is paying out of pocket, but we do know that what is left over is the patient's responsibility. Or, the patient may send it to their secondary insurer, such as Medigap. Now, we also get to see on the claims files what Medicare has decided to pay to the provider, their reimbursement. And I'll just talk a little bit about each type of service. So for hospitals, as I mentioned, most hospitals are prospectively paid. Now, there are actually some cancer hospitals that are not part of the prospective payment system, but you will still observe DRGs. Their claims will still largely look the same, but it's just that if you were trying to correlate the DRG that's listed on the claim with the payment, it will look a little bit different. But the way that the payment rate is calculated, so there's one DRG, and there's one base rate that's calculated, or there's one base rate per year, and then based on the DRG that's billed, there's a weight attached to it, so it's weighted. And then there are geographic factors, case mix factors, payments for indirect medical education or disproportionate share, which means that a hospital serves a disproportionate share of patients who don't have the ability to pay for care. There's also adjustments for transfers, whether or not someone has a full length of stay or whether there's a short length of stay. So there's a lot of calculation that goes into the payment, but in general, you can look at a DRG weight and look at the operating base payment rate and get pretty close. I mean, most of these adjustments don't end up adjusting the payment a whole lot in relation to the total bill. So we also do observe the patient responsibility, although, as I mentioned, it's really everything that's left over after Medicare pays. What happens is Medicare sets what they want the provider to be paid, then they pay their portion based on the benefit design, and then the rest is left over for the beneficiary. So there are separate fields for both beneficiary copayment and deductible. It's the amount that the beneficiary owes. It does not contain the amount the beneficiary actually paid. It's also possible that the beneficiary called up their provider and said, I'm not going to be able to pay this, and then they had some other negotiated rate. We just know that that is what Medicare thought the beneficiary should be paying after they've paid. We also don't know if they had other coverage that paid their responsibility. We have a little bit of information on Medicaid, but we don't necessarily know if there are other payers in there as well. So the deductible for hospitalization insurance, which is Part A of the Medicare program, is about $1,340. It changes by year, but this, it's been, it increases slightly every year, but it's one payment per spell of illness. So if you are like me and you're used to commercial insurance, usually there's an annual deductible. Medicare is a little bit different, so you may end up observing patients who pay a deductible more than once during the year, and that's because they have two separate spells of illness that just made them eligible to pay their deductible again. There's also coinsurance for hospitalization, although if it's a normal acute care stay that's short, they won't have any coinsurance. The coinsurance will kick in for long stays of 60 days through 90 days, and it increases. And then after the lifetime reserve days are used up, then all costs are borne by the beneficiary. There's also skilled nursing facility coinsurance that kicks in after day 20, and that, again, you can find on the Medicare website. It will change slightly every year. Part B, which is supplementary medical insurance, and this is essentially things that happen that are not hospital, that are not hospital, skilled nursing, or hospice. Here the deductible is much lower. It's only $183, and it is an annual deductible, but the copayments are generally higher. So usually Medicare will pay about 80%, and then the leftover 20% is the patient's responsibility. On the carrier file, the NCH file, there is something called the allowed charge amount, and it's almost always equal to the copayment plus the Medicare payment. I find that handy because that tells me what the provider got paid, and so, or what the provider should have been paid, I should say. And so it's kind of helpful if you're trying to look at, we did one study looking at how reimbursement affected the treatment patterns, and it was handy to have just that one thing. This is what the provider expected for this service. Sometimes you will find in the outpatient file that the patient will not pay a 20% copay. It's because it's something to do with the ambulatory payment classification that was billed through the hospital outpatient prospective payment system. And so it's something where you just might not see the 20% being paid. So there are some challenges. If you're interested in estimating cancer-related costs, we do have some challenges to discuss. You will not find one bill for all the costs associated with treatment, right? We've been saying this over and over again. There are multiple components of cost. So cancer-directed surgery may have its own cost, but it will also likely have many bills associated with it. It won't be just one bill that has all the costs associated with the surgery. You'll have to look, if you really want all of the cancer-related costs, you may need to look for chemotherapy, radiation oncology, other hospitalizations that may be related to a cancer. This is not a one-to-one relationship between each of these components and the bill. So, for example, for surgery, you may find the hospitalization where you have the surgery that took place. That will cover the patient's stay, their bed, their nursing care, the facilities, maybe some of their imaging that happened, and the operating room. But you'll also probably find in the carrier file, well, you almost always will find a surgeon bill and an anesthesiologist bill, pathologist, facility. The facility, like as I mentioned, the hospitalization will often appear on a separate bill. So if you're really interested in getting all of the costs, you have a couple of options. You may want all of the costs associated with that one inpatient stay for the hospitalization. So you could, use that one hospitalization, look at the admission and discharge dates, then look in the physician files for things that happened within that hospitalization date, within those date ranges. Unfortunately, there's not a linking number that will show this physician bill is related to this hospitalization. We're really limited to using the patient identifier and the dates in order to find everything. And with dates, you might not want to be super strict in requiring it to be exact. You may want to do, 1 day or 3 days of leeway in order to get everybody, because maybe the pathologist bills the day after the surgery or something. So you just want to make sure in order to collect everything. I highly recommend when you're doing this to print off a few cases. You'll do your match and then print off a few and see what you see in order to make sure that you're capturing what you want to capture. There's also a challenge in separating services and associated costs related to cancer from other health care. So you can do this by identifying specific procedures and services that are clearly cancer-specific. So surgical removal of a tumor, chemotherapy that's only directed towards cancers. So that's one approach to this is definitely cancer-related. If you're doing that, you may not get to see all of the complications that arise. So you may have to think about how you would want to capture those. You could also do a case control approach where you look at all costs, but you're looking at cancer cases versus matched controls without a cancer diagnosis and looking at the difference between the costs. You may also want to just identify a period where the majority of care is going to be cancer-related, peri-diagnostic period, or just looking at their surgery and looking at the hospitalization and things around that. And use statistical models to try to separate out the cancer costs from others. Just remember that the payment rules will vary by service type. So again, hospitals have that per spell of illness deductible and copayment. Outpatient services will have just that annual deductible as well as copayments, but some services that are received outpatient don't have any copayment at all. cancer screening, immunizations, bone mass measurement, wellness visits may not have any copayment associated with them. Now, if you are looking within the MedPAR and you want to see what Medicare has paid to a provider, it's a little bit trickier than you would think. So there is a payment amount that's on the claims, but if you want to know the total amount that Medicare paid for that hospitalization, you have to look at both that payment amount, the reimbursement amount, plus a total pass-through amount. Now, pass-throughs are things that Medicare wants to pay to the hospital on the basis of, sometimes they pay things like indirect medical education based on billed Medicare days. So they're not paying it based on the DRG that's being billed, but they're paying it because they owe it to the hospital. It's policy mandated that they're going to pay X amount per day. So there's a total pass-through amount on the MedPAR that's already multiplied by the days of utilization, so you can just use reimbursement plus total pass-through. There's also a field called primary payer amount. That would be the amount that's paid by another insurance before Medicare. Now, if someone has a car accident, for example, it may be that an auto insurer will pay for that hospitalization. So you may see things where there's a primary payer amount that's filled in and then the Medicare amount is zero. That means that a different payer has paid. For patients that are dually enrolled in Medicare and Medicaid, Medicare always pays first. So you can feel confident that you are observing the claims for that beneficiary. Even though they have a Medicaid benefit, you're going to be able to see something billed to Medicare first. The beneficiary responsibility for an inpatient stay will be sum of copayments and deductibles. And depending on where they are in their spell of illness, they may have no deductible associated with a given hospitalization, or they likely will, but they may have no copayments. If you really want to know the total payments to the hospital, then you'll want to look at the Medicare payments, the primary payer amount, and the copayment and deductible to know exactly what the hospital received for that hospitalization. I want to note that RESDAC, excuse me, does have payment calculation worksheets that if you are interested in, you can send an email to RESDAC. If you go to resdac.org, you can contact us and then get payment calculations worksheets, and it will show kind of where things are found on the files. And the variable names might be slightly different on the SEER-Medicare files, but it should get you most of the way there if you're really needing to calculate something like, I really need to know exactly which fields I'm looking at for the total payments from Medicare, for example. Physician and carrier payments, or NCH and carrier payments, are based on service. So it's actually one of the easier files to work with. If there's a CPT code that you're interested in, you can look at that line, and the payment that's associated with that line is, generally what's associated with that CPT code. I guess I should note for the MedPAR file, you will see a procedure code, but there won't be a payment associated with the procedure code. The payment is associated with the overall DRG that was billed, versus in the physician file, it's generally CPT code specific. Each line payment amount refers to the CPT code that's billed on that line. Now they actually do include a line interest amount, so if you really want to know the total amount paid by Medicare, it would be line payment amount plus line interest amount. In earlier linkages, it was only line payment amount. And just a note that you also can observe the beneficiary deductible and coinsurance by line. So you can look at a specific service and see the payment associated with it. If you want to know one claim can have multiple lines associated with it. If they saw a physician and they did a few different things on the same day, generally, there could be possibly more than one line. So if you wanted to look at the total claim that's associated with that line, you would use the claim payment amount. For earlier linkages, it's only the claim payment amount. And if you wanted the total beneficiary responsibility for the claim, it's the sum of the item copayments and deductibles for that claim ID. And again, the total payment due to provider will have all of the components. It will have the Medicare payment, the beneficiary payments, the claim primary payer amount. And again, this is usually equal to the allowed amount. So here it's a little bit, really the most simple to work with. You can look at the allowed amount, but that's what Medicare intends for the provider to receive. So the way that the file is structured, that the claim payment amount for each did have multiple per claim, just don't sum the claim payment amount. Make sure that you're only counting it once per claim. File is a little bit tricky. Claim can have multiple lines, but in here they are called revenue centers. And so it's akin to line items. Claim will contain at least 2 records. So this is in contrast to the NCH file, where the NCH file would have 1 line for every line item on the claim. Now the outpatient file has 1 line for every revenue center plus 1 summary record. And the summary record will always be revenue center equals 0001. So if you want to know that which one is the summary record, that's how you find it. For anything that happened after July of 2000, the outpatient file contains revenue center payments, but before that it contained total claim payments only. However, when ambulatory payment classifications came into effect, if you were to select in the outpatient file just on one service, if the APC is not associated with that particular service, it may look like the revenue center payment is 0, even though there may be payment associated with it. So you may need to step back and look at the total claim to see what's going on. The revenue center payment from Medicare can be found in the revenue center payment amount. The revenue center beneficiary responsibility is found in the revenue center patient responsibility payment amount. Earlier linkage years did not have all of this detail at the revenue center level. It only had the claim level. And just to note, that summary record that we talked about will have claim payment amount of 0. So it doesn't have the whole summarized information. Now, if we move up to the claim level, rather than the revenue center level, there is a claim payment amount, but again, like the NCH, it repeats on every line. So just make sure if you have more than one revenue center from a claim that you're not summing those, because they may not repeat. If in earlier linkages, the claim payment amount was only on the record, the summary record, so where it was 0001. And so if you were to select a revenue center item based on the HCPC code, and it would not necessarily have the claim payment amount. So again, I would recommend, as you're flagging your treatments of interest, really take a look at your file. Don't rely on, I know that this is the HCPC code that I'm interested in, so I'm only going to keep this. For your first couple steps of writing your algorithm, you're going to want to be looking at how it interacts with the file and making sure that if you need payment amounts, that it's keeping what you want. So you have your total claim payment amount. There's a total beneficiary responsibility that includes the Part D deductible, co-insurance, and blood deductible amounts. And then if you want the total payment due to Medicare, Medicare payment plus beneficiary responsibility plus primary payer claim paid amount, that will be the total amount that's paid to the provider. And again, if you ask ResDoc for those payment calculations worksheets, they go by file. So there's, we have it for inpatient, outpatient, NCH carrier file, all of the separate files if you are very interested in payments and you want to understand the breakdown. So you will see aggregate cost estimates from Medicare. So like, $104 billion in the United States in 2006 was spent on cancer. You can do it as a proportion of Medicare payments. It may help, predict future trends. You can use it to evaluate specific services. So you can look, this is the amount that's attributable to hospitalizations, this is the amount that's attributable to chemotherapy. You could look at a particular component of care, so care that happened at the end of life, to generate all of these estimates. Again, you could look at specific therapies. You could combine all of the therapies together to say these are all the cancer costs that we're interested in. And so we really need a hierarchical approach when we're analyzing these, though, because remember most of these things are billed across multiple claims, and so you'll need to sum them up and to get one. If you want everything that's associated with hospitalizations, you may need to include multiple components. You may also be interested in looking at longitudinal cost estimates, and again, SEER-Medicare data are well suited for this. Oftentimes people will want to use them for cost effectiveness analysis of cancer prevention, early detection, or treatment. You can, again, look at specific services or components of care. You can assess the care trajectory in relation to cost. You can stratify estimates by stage, the type of treatment that's received, the type of provider, type of surgeon, for example. You can also look at anyone who was newly diagnosed in 2010 versus everyone who was newly diagnosed in 2015. So the SEER-Medicare data are well suited for stratification. This is just an example of calculating the mean 5-year net cost of cancer. You can see that some cancers, brain, esophageal, lymphoma, have a high mean cost of care. When you look at the aggregate cost of care, you see a different story. You see that lung cancer has far and away kind of the greatest amount of costs associated with it, over $4 billion. And of course, that's related to the fact that lung cancer is much more common than some of those other cancers that may be more expensive to treat on a per-case basis. So for people who are interested in doing cost-effectiveness analysis, you may be wondering what measures of effectiveness you can find in the claims data. People are often interested in using quality-adjusted life years as their denominator. However, there's nothing in the Medicare claims data that there's no field for QALY. You do have information on mortality, so you know the life years, the life expectancy. Oftentimes, QALYs will be calculated separately for nursing home versus community dwelling people, and you could use the information that you have in the claims to kind of see whether or not you have people who are residing in a nursing home. And actually, the claims data are not as good for that, but there are assessment data that are available for all nursing home patients, and we'll talk a little bit about that in a minute. You will also have morbidity measures, so you have, length of stay, complications, readmissions, comorbidities. You have your CCW, chronic conditions. You can calculate risk adjustment scores based on claims diagnosis codes. We do not have information in the claims about health and functional status, so oftentimes there's, you want information about the number of activities of daily living for a person. But while it's not available in the claims data, if a patient is residing in a nursing home or if they are receiving home health care, there will be assessment data for them, and that is available through the SEER-Medicare linkage now. So you'll have clinical assessment data for nursing home residents and home care patients where you could look at their number of activities of daily living, for example. So in summary, the SEER-Medicare data are really a great opportunity for looking at population longitudinally for a variety of outcomes. And it includes a lot of what we're interested in. We're often interested in death as an outcome. We're interested in how much care costs. But remember that administrative data are not collected for research per se, right? We have to be extremely thoughtful about what's being measured and how we're defining our measures and what inference we can actually draw. And I think we have to be very clear about the limitations of what we have. But that I think that the data are still extremely useful in informing some of the questions out there. So with that,
we do have a number of questions after this segment. Thank you, Stephanie. We've had a number of questions related to approaches to identifying complications and how people might think about it. In your work, what are some approaches and resources you have used to try and pick apart whether or not something is a treatment-related complication versus an underlying condition?
Yeah, it is tricky. So I say I rely heavily on the clinicians that I work with. They have a good understanding of what could be reasonably associated with the treatment versus what is not. And, the longitudinal nature of the claims does really help if you are wanting to understand if something pre-existed, for example, the hospitalization. If you're looking at, is this AFib, during this hospitalization is the very first time it showed up, they've never had it before, versus you can look back and say, oh, well, this was actually probably something that pre-existed this hospitalization, so I'm not going to count it as a complication.
Another question that came up, again, we've seen this throughout the course, of what do you do if there's a conflict or not necessarily a complete alignment, particularly around death dates between SEER and Medicare? How do you approach that in your own research?
Mm-hmm. Yeah, so I actually, end-of-life care is one of my research interests, and my dissertation was on hospice, so I am familiar with this. For my personal research, I was interested in hospice use, and so I was using Medicare dates of death and relying on hospice diagnoses to say, why were they in hospice and when did they die? And I was interested in hospice length of stay, and that became tricky if I found a diagnosis date that didn't necessarily, or a death date, that didn't necessarily match their hospice discharge date. And it was something where we did a variety of things. First of all, I made sure that I had both their hospice discharge date and their Medicare death date and what the difference was, so that I could report that there were some people who had differences. It was a small percentage of patients, so I tried excluding them from my analysis and see, does that make a difference for my final answer, or the inference that I was drawing. And just reporting the fact that there were differences. Those were kind of the three things that I did.
Okay. Another question that came up was, could you just give us repeat the website for accessing the payment calculation worksheets? Where could researchers go to find those?
Sure. So www.resdac.org, and the payment calculation worksheets aren't actually posted to the website, but it's maybe even easier. You get to, there's a contact us link. You can just email through that, and someone will send them to you. So.
And then finally, how could researchers approach thinking about total costs of payment and which ones they might want to include in their calculations of costs of care or reimbursement for care?
Sure. I'm going to go back just one second. I realized that I said it again, www.resdac.org, but if you need the actual letters, www.resdac.org. I don't speak military letters, I apologize. But so if you're wanting to calculate total costs of care associated, again, I'm afraid I have to defer to the old, it depends on your research question, what you want to include. You may want to look at, if you're interested in surgery, for example, I would probably look at, if I can identify a hospitalization, then I would include all claims that fell within the dates of that hospitalization, including claims that are found in the NCH file. If I wanted to look at absolutely all costs, it might be the easiest then to have cancer. I have a non-cancer control. So you can say, well, they're well matched on all their comorbidities and their age and their location. and this is the actual difference that I'm seeing between people who don't have cancer and people who do have cancer. That's another option.
Okay, and then we have a number of other questions that are more study specific, so we'll follow up offline about those. With that, I think we're going to take a quick 5-minute break. We'll return at 2:40 Central Time and get started with how to request and publish with the data once you've received it. Thank you.